Good afternoon, everyone. Thank you for joining today's webinar, Test, Trace, and Space, Investing in a Health Workforce to Prevent Pandemic Spread. We're so grateful to Representative Lauren Underwood and the rest of our speakers for joining us today and look forward to a great conversation. A couple of housekeeping notes before we get started. Today's presentation is being recorded. The slides and recording will be made available. We will have a brief Q&A for Representative Underwood after her remarks, and there will also be time for questions at the end of the webinar. So please feel free to ask questions via the chat function, and we will also open up the phone line for the Q&A portions. With that, I will turn it over to Frederick Asasi, Executive Director of Families USA, to introduce the Congresswoman.
Thank you so much. It's a pleasure to be here. And we want to start by just really underscoring that America is in the throes of a profound health and economic crisis, a deadly disease, economic downturn, and an erosion of families' financial security. About 2 million people in our country have been infected with COVID-19, and over 110,000 people have died. More than 40 million people have lost their jobs since the beginning of the crisis, and 3 times more have lost income. Tens of millions of people do not have enough food to eat or know how they will pay next month's rent. And the crisis in healthcare coverage continues. Over 16 million workers lost employer-based coverage between mid-March and mid-May, the largest losses ever recorded. State and local governments are struggling to maintain healthcare services to our most vulnerable populations, and the pandemic has amplified healthcare disparities for people of color, with Black communities being diagnosed and dying of COVID at 2 to 3 times higher rates. This is no time to be complacent, especially when there is a path forward. In April, Families USA, along with over 400 partner organizations, came together to recommend and demand concrete action from Congress. We asked for action in 3 critical areas: comprehensive health care coverage, financial assistance for state and local governments, and the programs that they run to support families, and a comprehensive and coordinated public health response to the pandemic. We continue to advocate for all 3 of these critical priorities to secure family and community health and stabilize our economy. And we need champions in Congress to get us there. Today, it is truly a joy to introduce Congresswoman Lauren Underwood to talk about her leadership during the COVID crisis, and in particular, our 3rd priority, a comprehensive science-based public health response to the pandemic. She's leading efforts in the House of Representatives to bolster our frontline healthcare workforce and improve access to COVID-19 testing and contact tracing in communities across the country. A nurse by training, Congresswoman Underwood shares our belief that in the wealthiest nation in the world, every family should be able to access the health and healthcare they need to live to their greatest potential. In Congress, she is focused on protecting people with pre-existing conditions, lowering health insurance premiums and drug prices, and expanding access to mental health care services. Prior to her election to Congress, she worked with the Medicaid plan in Chicago to ensure that it provided high-quality, cost-efficient care. She also served as a senior advisor at the U.S. Department of Health and Human Services, helping communities across the country prevent, prepare for, and respond to disaster, bioterror threats, and health emergencies. In the midst of this current health crisis, Congresswoman Underwood has once again stepped up to the plate, joining her colleagues Jason Crow of Colorado and Jim Panetta of California to introduce H.R. 6808, the Health Force and Resilience Force Act, a bill Families USA is proud to endorse. This important legislation would create a program to train and deploy essential public and community health frontline workers to support local testing, contact tracing, and potential vaccine administration efforts. In addition to help solving our health worker shortage, the bill would help provide jobs for thousands of recently unemployed Americans and is the key to being able to successfully restart our economy. The legislation is championed in the Senate by Senators Michael Bennet of Colorado and Kirsten Gillibrand of New York. Congresswoman, on behalf of Families USA, I want to thank you for everything you are doing to improve health and equity in our communities and for taking the time to share your thoughts with us today.
Well, thank you, Frederick, and thank you to Families USA for hosting this event and for your deep commitment to ensuring that every American can access quality, affordable health care. And thank you for your support of the Health Force and Resilience Force Act. I'd also like to thank the National Coalition of STD Directors for your support of the Health Force bill as well. As a public health nurse, I know the importance of making investments in public health. However, years of underinvestment in public health have become painfully apparent during this pandemic. We need to make significant investments in our public health infrastructure right now so that we can prevent further spread of this virus. And we need to sustain those investments even after the pandemic is over so that public health departments can continue their important work and so that we're prepared for the next infectious disease outbreak, which is why I joined Representatives Jason Crow and Jimmy Panetta in the House and Senators Kirsten Gillibrand and Michael Bennett to introduce the Health Force and Resilience Force Act. The Health Force and Resilience Force Act is a bold initiative inspired by the Depression-era Works Progress Administration and Civilian Conservation Corps to provide job opportunities to Americans looking for work in their communities, building the public health infrastructure that our nation will need during COVID-19 and beyond. First, the bill will provide up to $55 billion per year to enable local, state, tribal, and territorial public health departments to hire, train, and employ hundreds of thousands of Americans to meet each community's most pressing public health needs. This approach would call for public health departments to hire local community members to be a part of this health force, supporting efforts like testing and contact tracing. Members of the health force would also find pathways to post-emergency response careers in health departments, helping to prevent the spread of other infectious diseases and supporting other critical public health work. In addition to establishing the health force, our bill would also establish a resilience force through FEMA to hire workers who can provide logistical support in procuring medical equipment for COVID-19 response efforts, and also assist with other disaster preparedness responsibilities, like ensuring that communities are equipped to respond to a hurricane in the middle of this pandemic. Our bill is not the only proposal in Congress to provide funding to bolster our nation's public health workforce. However, it is unique among these proposals for a few reasons. First, the health force prioritizes the hiring of local community members to support the current and future work of public health departments. As you'll hear from the National Coalition of STD Directors later, contact tracing in particular demands a high level of cultural competency. The best way to ensure that our public health workforce knows the community it's serving is to build a public health workforce from that community. Second, the health force makes a sustained commitment to the communities it serves. Even after this pandemic ends, health departments will need continued support for the critical public health work they do year-round. The health force will provide this ongoing support, making a commitment to our communities that extends far beyond COVID-19. And finally, my bill recognizes the need for investing in the workforce that will be necessary to conduct sufficient levels of testing and contact tracing. The Harvard Global Health Institute has estimated that the U.S. will need to conduct 900,000 tests a day to reopen safely. This requires not only the tests and the lab capacity to process tests, but also the personnel to administer them. There are also proposals to conduct contact tracing using phone apps. However, during an Education and Labor Committee briefing last week, Dr. Ashish Jha, the director of Harvard Global Public Health Institute, emphasized how critically important it is to have trusted community workers doing this work instead of relying on technology. As Dr. Jha stated, there's no app for cultural competency. The health force is the proposal that leads this moment and uniquely addresses the greatest public health challenges we're confronting. We're facing a once-in-a-generation health crisis, and the scope of this health crisis demands a proportional health response, including significant investments in public health and healthcare. That's why, in addition to the health force, I'm actively working to advance policies that will protect access to care and make healthcare affordable for all Americans. The stakes couldn't be higher. In the midst of a global pandemic, the Trump administration is pushing a lawsuit that could cause 54 million Americans to see their pre-existing condition protections eviscerated. We need to protect health care for people with pre-existing conditions, and we need to continue the effort to roll back JUC plans that don't offer protections or access to needed care. We also need to ensure that people who need affordable insurance can get it. That means reducing the cost of premiums for ACA plans by expanding tax credits to more people and making them more generous, as my Healthcare Affordability Act will do. I appreciate the advocacy of groups like yours, and we will need you to continue to make your voices heard in the coming days, weeks, and months as we elevate the urgency of advancing health policies in response to COVID-19. I'm happy to answer a few questions at this time. Thank you.
Thank you so much, Congresswoman. So we will now open it up for a brief Q&A while we have you on the line. Operator Karina, can you see if anyone has questions on the phone?
Certainly. If you'd like to ask a question on today's call, please press *1 on your telephone keypad. If you're listening today using a speakerphone, please pick up your handset before pressing the corresponding digits. A voice prompt on the phone line will indicate when your line is open. Once again, please press *1 at this time if you have a verbal question. We'll pause for just a moment.
Great, thank you. And we welcome folks to continue asking questions on chat. So while we're waiting on the phone line, we can go ahead and ask one of those questions. We know that communities of color are disproportionately impacted by COVID-19. How can we ensure that the health force and resilience force will bolster the response in these communities in particular?
Yeah, that's such a wonderful question because we know that COVID-19 hasn't affected all communities equally. In April, the Centers for Disease Control and Prevention reported that Black Americans have been hospitalized from COVID-19 at disproportionately high rates. And the COVID Tracking Project found that Black Americans are dying at a rate nearly 2 times higher than their population share. These trends reflect and likely exacerbate underlying health disparities that already existed in communities of color, resulting from years of discrimination and underinvestment. And so the health force makes direct investments in communities, allowing the local health departments to hire people from the community to join their COVID-19 response efforts and to support ongoing public health work after the pandemic.
Great, thank you so much. And another question is, how will the health force overlay with the state-based contact tracing efforts that are already underway in states?
Yeah, the good news about contact tracing is that we already have an existing infrastructure built into our public health departments. And I think that what gets overlooked a little bit in these conversations is that our local public health departments have been operating at the top of their capacity for years, and then they've operated at the top of their capacity plus some, right? Everybody's dug deep during COVID-19. And so through disease intervention specialists, state and local health departments have years of experience conducting contact tracing for STDs and other infectious disease outbreaks. And so what our health force will do, it'll strengthen the existing contact tracing infrastructure in our local public health departments, bringing in additional workers from the community to meet the unprecedented need for this workforce. And then obviously it's a sustainable solution that helps bolster local public health departments for years to come.
Wonderful, thank you. And Karina, are there any questions on the line? And we would just ask if you do have a question, if you could start by stating your name and organization.
We do not have any phone questions at this time, but once again, that's *1 if you'd like to join the queue.
Great, thank you so much. And I'll also just mention that we have Jack Mateo from Representative Underwood's office who will stay on the line till the end of the webinar in case there are further questions regarding the Health Force and Resilience Force Act. But one question we do have is just advice for advocates specifically in their states and how they can be most helpful in supporting this legislation.
Well, we know that we have work to do even to move this bill in the House. So everybody has a member of Congress. Most of the members of Congress are at home in their districts right now. We're doing lots of outreach every day to different segments of our communities. And so you should reach out to your member and ask for a meeting and let them know, give them an update on all of your work and let them know how this type of a bill would be helpful to improving and enhancing your community's response to COVID-19 and allow a swift reopening and speedy economic recovery. You know, I think that we've been so acclimated to having to engage our senators, and that's such an important part of the conversation as well. But right now we're in a moment where it would be time to engage the House of Representatives. And we've been talking with our colleagues. There's as I mentioned and alluded to in my comments, there's a variety of solutions under consideration. And, you know, we think that this is the best to help all communities, particularly those that are vulnerable and underserved. get access to the workforce that we need to properly do the contact tracing.
Thank you. So we have a couple questions in the queue, but I want to be mindful of your time, Congresswoman. Are you able to stay on for a minute, or should we pose those to Jack at the end of the webinar?
If you have one more question, I can take it.
Okay, great. The first one, I'm part of a certified application counselor organization, and we could help people get insurance if there were a special enrollment period due to this national crisis. We also need an extended open enrollment period for FFM states. Who is addressing this? And this is somebody who lives in North Carolina, which is not a Medicaid expansion state.
Yes, so I am gravely concerned about the special enrollment period. I've introduced a standalone bill to offer a special enrollment period, and then we also included that in the HEROES Act. And so that is the bill that we passed out of the House in May, and we're waiting for Senate action to occur. So, yes, we need to make sure that all Americans can get the care that they need at an affordable rate, and making sure that they're covered is a critically important aspect of that. Thank you for your work.
Thank you. One last question. Some states are only allowing their health departments to run their contact tracing programs, and they don't have the manpower to do it alone. How can we get our states to reach out to non-health department personnel to train and assist?
Well, that's why I think that these grant dollars are going to be so important in setting up a program like this. I mean, a lot of the challenge that states are facing right now is that they just can't afford. They can't afford to do the work because of the outlays, the COVID-related outlays that have been made, and also the decreased revenue that they're bringing in, sales tax revenue and other items. Illinois, for example, has been very hard hit economically, and as part of the HEROES Act, we have $500 billion to support states, counties, and cities who have taken a big hit, and their essential services are being threatened right now. I think that we all can work with our states to help them understand the evidence base and the best way to bring on staff in order to properly conduct the contact tracing. But I do think that there is a real just basic financial element to this, that they can't afford to bring on new people without some support for their salaries and new program efforts. And so, we know that at a federal level, or at least I'll say it like this, I know at a federal level we need to pass this type of legislation and offer our states, counties, and cities these kinds of resources. And I think that this health force and resilience force is the best way to structure that kind of assistance for our communities.
Okay, well, thank you again, Congresswoman, for joining us and for your ongoing work to improve healthcare access and equity in our communities. Again, we'll have Jack Mateo from Representative Underwood's office on the line in case there are further questions regarding the Health Force and Resilience Force Act. And now we'll go ahead and turn it to Amanda Dennison from the Deputy Executive Director for Programs at the National Coalition of STD Directors, who will be talking about contact tracing as being key to infectious disease control.
Great, thank you so much. Next slide, please. Thank you. Today I'm just going to provide a brief overview of disease intervention activities, including the history of DIS in the country, their training needs, and the adaptation of these activities to support the COVID-19 response efforts. Next slide. Disease intervention specialists, also known as DIS, have been on the front lines of public health for decades. The work of DIS originated in the 1930s as a key strategy to address syphilis, which at that point in time was endemic in the U.S. At the time, health departments used their local capacity to make sure that every person diagnosed with syphilis was treated, partners were identified, contacted, and received testing and treatment if necessary, and that the source of infection was identified. CDC first established the federally funded workforce to increase local capacity to control syphilis in the 1940s. This was expanded in the 1970s as DIS began investigating gonorrhea, and again expanded in scope to include HIV in the 1990s. The idea is that DIS can interrupt disease transmission by contacting those recently diagnosed with an infectious disease, in this case STDs, and identifying others who have been exposed or have a potential exposure to the disease. Once identified and located, DIS are able to test and treat contacts, preventing further transmission. The work of DIS has grown significantly to meet the demands or the needs of communities over the years. DIS now offer linkage and relinkage to care, referrals to social services, and linkage to PrEP and PrEP follow-up. While these activities can be time-intensive, the work of DIS is still considered to be one of the most effective means of case finding. The system of disease intervention has proved successful across the country. But to be a successful disease intervention specialist requires specific training to develop very specialized skills. Training needs are based on a very comprehensive job task analysis done by the CDC and several national organizations, including NCSC. Training topics based on that job task analysis include field investigation, field testing, client interviews, client engagement and counseling, partner elicitation and notification, cultural humility and linkage to care and wraparound services. The extensive training that DIS receive allows them to develop valuable skills that are adaptable and can support outbreak investigations of other infectious diseases and public health emergency preparedness efforts. Of course, we are now seeing this with COVID-19. Next slide. Contact tracing is a vital component of the COVID-19 response. States across the country are drastically ramping up their contact tracing efforts and hiring hundreds or thousands of contact tracers in each of the states. Many of the contact tracers joining the COVID response have little to no public health experience. States are currently pulling staff from governmental agencies such as education, public safety, and others. We are also seeing those who have been unemployed during this time or furloughed during this time also joining the contact tracing effort. To become successful in these efforts, they of course need at least a foundational training to get started. NCSD, in partnership with ASTO, the Association of State and Territorial Health Officials, developed a free training to address the immediate training needs of COVID-19 contact tracers. The training, entitled Making Contact, a Training for COVID-19 Contact Tracers, launched on April 28th of this year. As of last week, more than 30,000 people have completed the training, and more than 15 states have integrated our training into their required training for new contact tracers. Our training currently offers 4 modules and takes 2.5 to 3 hours to complete. The first module focuses on the basics of COVID-19, including key terms, transmission, symptoms, and prevention. The second module covers the basics of contact tracing. We discuss key terms in COVID contact tracing, the goals of contact tracing with 3 different entities, we'll say, which include the patients, the contacts, and the community. We also covered the 4 fundamental parts of contact tracing as outlined by CDC. Our third module covers effective communication and interviews. We focus on developing communication skills and how to conduct successful interviews with patients and contacts. Our last module covers case monitoring and resources. The module provides information on different types of case monitoring and linking patients and contacts to wraparound services such as medical care, food delivery services, housing, etc. Each module includes a knowledge assessment, and learners must pass all assessments with a score of 100% in order to complete the training and receive their free certificate. We do currently have additional modules planned with new support from CDC, which will be launched in the coming months. The additional modules will focus on health equity, advanced case investigation activities, and the supervisory role DIS play in the COVID-19 response. Next slide, please. I would like to thank Representative Underwood for her work on the Health Force and Resilience Force Act of 2020. To hear the acknowledgement of the existing DIS workforce and their expertise at the local public health level is very encouraging. NCSD, along with ASTO, APHL, CSTE, and NACHO, support a contact tracing workforce consisting of 3 tiers, which aligns with the Act. The first tier includes 100,000 entry-level contact tracers. The second supports 10,000 DIS who will supervise the new contact tracers. And the third tier includes 1,600 epidemiologists to support advanced surveillance activities. NCSD will continue to push for funding to flow through CDC in order to support this 3-tier approach to ensure an adequate contact tracing response to COVID-19. Next slide. We know the systems of disease intervention that include DIS at local and state health departments are successful. The HIV hepatitis outbreak in Indiana in 2015 is a prime example. It was a DIS in Scott County who first discovered the outbreak while conducting routine HIV investigation activities. This DIS sounded the alarm within their health department, launching the outbreak response. DIS then carried out many of the outbreak response activities, including field testing, drawing blood, interviewing cases and contacts, linking people to HIV and hepatitis care and other services, surveillance data entry, and more. Other examples of DIS assisting with outbreaks include hepatitis A outbreaks, which have occurred across multiple states in the last several years. In these outbreaks, DIS are often relied upon to work with the most vulnerable populations in their communities, such as those experiencing homelessness. DIS have also been utilized in the Ebola and Zika response to interview and monitor travelers, link any potentially ill individuals to care, and complete basic surveillance activities. While we've never seen anything like COVID-19, it is now another example of contact tracing and DIS conducting and meeting vital public health response. Next slide. This slide includes several resources that are key to what NCSD is doing currently and the contact tracing efforts nationwide, including the contact tracing resources from CDC, the training that NCSD and ASTO have launched, and the COVID Command Center for STD programs that NCSD currently has on our website. Next and final slide. And that is it. Thank you so much.
Thank you so much, Amanda. And now we'll turn it to Kelly Murphy of Families USA.
Yes, hi there. Hopefully you guys can hear me okay. Thank you again so much for joining us today for this really important conversation. I wanted to start by just saying that at Families USA, we've been calling really for a comprehensive effort to test, trace, and quarantine individuals, something that's nationally coordinated, implemented in states and localities across the country, and this includes a call for more than $46 billion to support these sort of 3 science-based functions. So today I'm also going to focus my remarks on contact tracing efforts and particularly the role that community health workers can play as a ready and effective workforce. Next slide, please. So I thought we'd start take a quick sort of national picture look with a brief overview of contact tracing efforts in the states across the country. This map was created by the National Association of State Health Policy, also called NASHP, and shows really the widespread efforts to ramp up contact tracing across the country. States are clearly focused on a few types of contact tracing programs. The majority are looking to stand up their own in-house state-based programs. I know we already got a question on that. Some are also focusing on partnership opportunities with public and private entities, and a few more are executing contracts with non-governmental entities. Oh, sorry, next slide. So as I mentioned, contact tracing really exists within the context of other strategies. Without access to effective and reliable testing, without access to quick, effective, reliable testing, a quick follow-up with case investigations and contact tracing would be effective at its job. It sounds like I'm echoing a little bit, so I'm just going to move 2 seconds. Sorry for this movement, but I just got a note saying that I was sounding a little bit echoey. So guys, if I'm still echoing, please let me know. Okay, but back to this slide. So similarly, once contacts of an infected individual have been identified, there must be supports and resources in place to help them effectively isolate, quarantine, which sometimes means providing things like temporary housing, food delivery services, or income support. Next slide. So, why is contact tracing important? And folks on the call, I think, have already made many really good points about the effective work that contact tracers do. If you're like me, you've heard the term community spread on a regular basis now, and this really means that infected individuals are likely to spread COVID-19 to 2 to 3 other people. So the goal of contact tracing is really to break that chain and stem any additional spread. If done effectively, and especially in the case of COVID-19 needing to be done quickly, it really can be effective at stopping new infections. So as you have heard, contact tracing can be really labor intensive, and in most states it requires person-to-person conversations. So states are tasked with standing up these really large-scale workforce operations quickly and with the right individuals. So I also wanted to note that CDC says that contact tracers should have things like really excellent interpersonal skills, cultural sensitivity. They should speak the language of the folks in the community. They should have interviewing skills, all the things that are really needed to develop, sort of quickly develop, trusting relationships with individuals. And really, when you think about this description, it aligns with how we at Families USA and beyond think about community health workers. So one of the quotes from a community health worker herself I wanted to insert into this and make sure that their voice is really loud and clear on this issue is that, community health workers are really already an important part of the public health system, and they are ready to contribute to these contact tracing efforts. They have specialized skills. They have existing community relationships that are incredibly critical to this work, and we just felt like they are a really ready and willing workforce integrated into these contact tracing efforts. Next slide. So who are community health workers? They go by many names, and they really do vary by state. They work, like their name implies, out in communities. They are in clinics. They are in pediatrician offices. They are in homes. They are in schools, and really beyond. It just kind of depends on the model and the state and the community. Next slide. Like their titles, the role of CHWs can really vary widely, and they're doing many essential services, as you can see, out in the community on a regular basis. I think at the end of the day, CHWs have really 3 core functions that are especially helpful to a COVID-19 response. First, they have existing relationships with individuals and healthcare systems in the community already. Second, they understand community culture and they speak the language. And third, they already know how to connect people to needed services and supports that exist in the community. And in this capacity, they can really help individuals as part of the contact tracing process, but they can also extend beyond that role of just a contact tracer and help communities kind of weather the crisis more broadly. Next slide. So it's also critical to underscore that CHWs have had success in improving health outcomes, particularly in underserved communities. It's especially important for COVID-19, where, as Congresswoman Underwood was talking about, there has been really a greater impact on communities of color and low-income communities. So by instilling CHWs in the role of contact tracer and, again, beyond, as I mentioned, they can bring their whole model to bear on communities that really need it the most. Next slide. So today I will leave you with these 5 recommendations that we are going to be making to states on how to stand up contact tracing efforts that include the existing and robust workforce of community health workers. First, states should think of CHWs first as they recruit a workforce. Second, they should dedicate funding in contact tracing. You know, these are not volunteer positions. These are really, need to be fully funded. And again, for sort of the full scope of the work that CHWs can do, because it can apply to COVID-19, but then again, beyond as well. Third, tap into existing CHW workforce that's in a state already and also hire new ones, because I think this is a good way to improve the model of the CHW and really be able to expand moving forward into other health issues. Fourth, engage community-based organizations, state and local CHW networks and associations that already exist. Certainly county health departments need to be engaged in this effort as well. And fourth, or fifth, this is a point that I've made a couple of times, but look for CHWs for COVID-19, but also beyond. They are already and can become an integrated part of improving COVID-19 health outcomes and, again, health outcomes more broadly. So I think, Lauren, that's all I have. I'll turn it back over to you.
Great. Thank you so much, Kelly, and thank you again to all of our speakers for sharing their expertise today. So we hope that the tools and information that was shared today will help all of those on the line take action in your state. We continue to update the COVID-19 response toolkit with timely resources and analyses to support you. And we also invite you to share your feedback on this webinar and other ways that we can support you in your work in the post-webinar survey. So we'll now go ahead and move to the Q&A portion. As a reminder, we have Jack Mateo on the line to field questions for Representative Underwood's office. If you're signed into the web platform, you're welcome to continue posing your questions through the chat box. And Karina, does anyone have questions queued on the phone?
And we do not have any in the queue at this time, but once again, that's *1 to ask your question verbally.
Okay, great. Thank you so much. So I think the first question I'll pose to Jack, and I'll encourage any other speakers to chime in. So given the anti-immigrant sentiment nationally and at the federal level, what steps are U.S. representatives doing to assure trust for case management needed in the contact tracing for COVID-19?
Yeah, thank you so much for the question. And again, thanks for hosting the Congresswoman for this really important event. I think it's a great question and obviously an important issue. We know that the virus, of course, does not discriminate based on someone's immigration status. And the health force has been really carefully designed to ensure that, as the Congresswoman emphasized, that we have members from the community who have cultural competency, linguistic competency, and can instill confidence in people who might have been exposed to the virus to ensure that we can engage in the effective contact tracing work that's needed. And I'll certainly defer to Amanda and Kelly to provide more information on the work that disease intervention specialists and community health workers are already doing in that space. But that is a real priority for the health force and for our broader efforts to make sure that we contain the spread of the virus.
Great, thank you. And we also had a question about, for folks who live in areas where folks are starting to ignore social distancing guidelines and starting to gather what is the kind of responsibility of state and local officials to really prevent these, to make sure that folks are continuing to adhere to these guidelines, given that it can be even more challenging for contact tracing to occur in these instances?
Lauren, this is Kelly. I can talk to this, and I'm sure there are probably others on the call too who can chime in. But one of the things that families we've been talking about is really sort of a nationally led, very clear, coordinated strategy with evidence-based guidelines being communicated on a regular, daily basis to the American people. So I actually would kind of take this up a level and really call for that accountability from the federal government to be providing a lot of this really critical information to then filter down to states and localities. And certainly there should be things, flexibility built into what states and localities are doing. But I really think some better leadership from the top would be really helpful in a lot of the challenges that have been raised in that question. So I would urge people to, of course, connect with their local folks and everything and their representatives and sort of make it clear that we need more guidance. I think that there has really been a lack of guidance, and probably, having CDC talk about their guidance daily on some sort of daily briefing would be really helpful, at least to just get the best practices out there. And then certainly the implementation level, needs some work too, and nothing will be perfect in a crisis response. But I'd ask for, levels of leadership sort of up and down the chain.
This is Amanda. I would echo that. We have many members who I think are developing their strategies for addressing COVID, especially as states are reopening, sort of on the fly without official guidance, doing what they believe is best based on the science and what we currently know. And we've utilized, as we were developing our training, we were utilizing what the states had provided us in terms of what they have already developed. So in many senses, I think our members are ahead of where some of the federal guidance is at this point. So additional leadership would be much appreciated, I think, by our state and local members.
Thank you. And I think, I don't know if Amanda, if you want to chime in on this one, and I think others will have thoughts as well. I've heard that some states are trying to use a volunteer model, and I'm glad to see that you have recommended that these positions be funded and paid. I would like to be pointed to the arguments for this, since we've been operating under a volunteer model for the long-term care omnibus program in the nursing home context, and that has not been effective.
Sure, I will speak to what I know, which is that we have certainly heard that the volunteer model is not working locally. I think that what I spoke about in the presentation in terms of DIS has very specialized skills, and it takes training to develop those skills. And the folks that we are bringing on to become contact tracers deserve the investment of being funded and paid to do that work and to go through that very specialized training in order to make contact tracing effective. Because without those skills in terms of how to talk to community members, how to talk to community members that you're not a part of, understanding effective communication techniques, just the basics of contact tracing. There's a lot there to learn, even beyond what ASCO and NCSD provide. So to be able to invest in that training and to make contact tracing effective, NCSD certainly believes in the model of funded and paid contact tracers versus the volunteer model.
And Lauren, this is Kelly. I would chime in too and just echo everything Amanda just said. And, we've had lots of communication with community health workers themselves and leaders in the community health worker sort of arena. And, I think they always point to all the really the skills that are needed to do this. So you're going through training, you're learning how to develop effective relationships with people quickly. You're learning all the, services and supports that are available in communities. You're making linkages. Like people are it's a really hard job. You're doing person-to-person interaction and talking to people about really serious health issues. I mean, you are doing a ton of work on this, and I think in general it's easy to think about, your work and level of effort when you're thinking about something as a volunteer position versus something that is your, professionalized job that you are going to on a regular basis. And there really is, if we want this to be successful and we want people to really put their effort into this and contribute all of their amazing skills, I feel like it's hopefully a natural argument to make that it should all be paid and fully funded. And there should be federal grant dollars to bolster the payments that are able to go to these folks as well.
Great, thank you. The next question I'll pose to Jack. So many existing community health workers are already employed, and Chicago has shown a great example of community-based contact tracing through investing in partnerships with trusted community-based organizations. A persistent question is how these existing community health workers can integrate contact tracing, testing, or other COVID-19 response services with their current job duties. Does the health force legislation take this into account? And separately, how do we leverage this additional federal attention and funding to advance financially sustainable for community health workers and beyond COVID-19 response?
Yeah, thanks so much. That's a great question. And I think one of the most important elements of the health force, again, that might distinguish it from other legislation designed to promote testing and contact tracing, is that it's really about a partnership model, and it's really about getting funding through CDC to our state and local entities that are already doing this work and building out the partnerships, amplifying the work that's being done, like you mentioned, in Chicago, with more funding. Of course, Amanda and Kelly mentioned some of the funding levels that groups have been supportive of. The health force is a robust investment of $55 billion a year. We know that the HEROES Act included $75 billion for efforts like these. So I think in many ways, what our intention was with this bill was to lift up those models that are already working in communities, particularly recognizing, as the Congresswoman said, that our state and local entities are facing severe fiscal challenges right now as a result of the pandemic. And if we can get the financial resources that our state and local health departments and their partners need to continue their work, in addition to the additional workers, we think that would be the tools that our communities will need to reopen safely.
Thank you. And just wanted to pause to see if, Karina, if we've received any questions on the phone line.
We do not have any phone questions at this time.
Okay, great. Thank you. So one other question we had on the chat is how do you, any advice for community-based organizations on how they can really effectively engage with state efforts to ramp up testing and contact tracing? So I don't know if Amanda, if you want to start with any thoughts that you have.
Sure. A lot of what we're seeing through our members is the networks that they have for STD and HIV testing being utilized for COVID testing. We know that several community-based STD clinics have adapted and pivoted to providing COVID testing because they serve those vulnerable communities. They're a known entity. They're trusted within the communities. So those community-based organizations, I think, make a perfect fit for providing the testing services. So we are seeing that across our membership at this point in time, and I think it makes a lot of sense for those very reasons that I just mentioned, in terms of them already being a part of the community, being trusted, and being known, a known kind of safe space for people to engage in care.
And this is Kelly. I can chime in too on this one about sort of engaging in this, because it's a great question. And sometimes you feel like state officials are just moving a mile a minute, and you're saying, hey, I'm over here. I can help you. You know, how can I do that best? A couple of thoughts. I would look to find out, and you can visit that NASHV map even to find out what type of system or what type of contact tracing workforce your state is actually standing up. It might be an entirely state model, it might be a public-private model, it might be a contracted model, and they have some good information on sort of who's doing what, which I think will help you understand, you know, where the best contact points are. Another thing to recommend is get in touch with your universities, your public health schools in particular. I know that there is a ton of work being done, you know, recruitment surely, but also I think strategy work, because those are, you know, tons of innovation is coming from universities. So think about linking up with your universities and seeing what they're doing, and if they're a part of the efforts, that might be another place to kind of get in and have a conversation and offer services. If you can't get in, and, you know, well, I know you can't physically get in, but if you can't connect with your sort of state officials and have a meeting with them on things that you can do. But community voices really matter, and just like Amanda said, you're doing incredible work. You're already doing this incredible work, and you can really, you know, pitch yourself as an extension of what's already happening. So I just wanted to mention those couple of other avenues.
Great, thank you, Kelly. And we would also just, you know, as we, you know, invite folks to share any final questions in the chat. We'd also just, you know, encourage you to follow up by email with any questions, any ideas or experiences that you have on these topics. So thank you all again for attending today's webinar and engaging in this conversation. We hope that it gave you some ideas on how you can take action in your state. And we also want to make sure that you're aware of the next webinar that we have coming up. That's on Thursday, June 18th at 2 p.m. Eastern Time. The topic is addressing the fiscal crisis in communities affected by COVID-19. So we'll share more information on that webinar for those who registered. And we'll also share the recording and the slides, as well as the resources that we mentioned on this call. So thank you again for joining today, and we hope you have a wonderful rest of your day, and stay well.